Hello everyone, welcome back to Expert Medical Coding. In today's video, we are going to learn about ICD-10-CM Chapter Specific Guidelines, Chapter 1, Part 4. In this video, we'll be covering MRSA infections and Zika virus. So let me read the guideline first, then we'll understand it in more detail. So the first guideline under selection and sequencing of MRSA codes is combination codes for MRSA infection. When a patient is diagnosed with an infection that is due to MRSA and that infection has a combination code that includes the causal organism, example sepsis, pneumonia, assign the appropriate combination code for the condition. Example code A41.02 for sepsis due to MRSA and J15.212 for pneumonia due to MRSA. Do not assign code B95.62 methicillin resistant Staphylococcus aureus infection as the cause of disease classified elsewhere as an additional code because the combination code includes the type of infection and the MRSA organism. Do not assign a code from subcategory Z16.11 resistance to penicillin as an additional diagnosis. So let's break this down in simple terms with examples. First, what is MRSA? So MRSA stands for methicillin resistant Staphylococcus aureus. It's a type of staph bacteria that has developed resistance to many antibiotics. So the guideline clearly states here, when a patient has an infection due to MRSA and the infection has a combination code that includes both the condition and the organism, you should assign the combination code. For example, A41.02 code, sepsis due to MRSA. Here, sepsis is an infection, MRSA is an organism. So the combination code here is A41.02, that is sepsis due to MRSA. Similarly, J15.212, pneumonia due to MRSA. Pneumonia is an infection here and MRSA is an organism. And the combination code here is pneumonia due to MRSA, J15.212. Do not assign B95.62 MRSA as cause of disease classified elsewhere as an additional code. Why? Because the combination code already includes the MRSA organism. So we should not separately code B95.62 here. And also do not assign Z16.11 resistance to penicillin as an additional code. Why? Because when you use combination code like A4102 sepsis due to MRSA, J15.212 pneumonia due to MRSA, these codes already mean that the Staphylococcus aureus is resistant to methicillin, which is a type of penicillin. So if you also add Z16.11 resistance to penicillins, it would be double reporting the same information. So that's why we are not going to code Z16.11 along with these codes. Let us see an example. Patient admitted with sepsis due to MRSA. So the correct code here will be A41.02 combination code. And the example 2, patient diagnosed with pneumonia due to MRSA. Correct code here will be J15.212. Let's move towards the next coding guideline that says about other codes for MRSA infection. When there is documentation of current infection, example wound infection, stitch abscess, urinary tract infection due to MRSA, and that infection does not have a combination code that includes the causal organism, assign the appropriate code to identify the condition along with the B95.62 code, that is MRSA, as the cause of disease classified elsewhere for the MRSA infection. Do not assign a code from subcategory Z16.11 resistance to penicillins. So let's break this guideline. So when there is documentation of a current infection due to MRSA and that infection does not have a combination code, you must assign two codes. The code for the condition itself, example wound infection, stitch abscess, UTI, cellulitis, etc. And along with that, you also have to code B95.62 MRSA as the cause of disease classified elsewhere. So do not assign Z16.11 resistant to penicillins because MRSA inherently means penicillin resistance. Let us see an example. The patient has a post-operative wound infection due to MRSA. So here the correct coding will be two codes we have to give. That is the first one for the infection following a procedure, T81.4XXA. Along with that, we also have to code B95.62 MRSA as a cause. Why? Because the first code, infection code, doesn't have a combination for the MRSA. So we have to code that MRSA separately. Example 2, patient diagnosed with urinary tract infection due to MRSA. Here also, we have to code two codes. First code is N39.0, that is UTI, site not specified. And along with that, as this code is not covering the organism, we have to code a separate code for the organism, that is B95.62 for MRSA as a cause. Now let's move towards the next coding guideline that says about methicillin susceptible Staphylococcus aureus and MRSA colonization. The condition or state of being colonized or carrying MSSA or MRSA is called colonization or carriage, while an individual person is described as being colonized or being a carrier. Colonization means that MSSA or MRSA is present on or in the body without necessarily causing the illness. A positive MRSA colonization test might be documented by the provider as MRSA screen positive or MRSA nasal swab positive. So assign code Z22.322 for carrier or suspected carrier of MRSA. for patients documented as having MRSA colonization. Assign code Z22.321 carrier or suspected carrier of methicillin susceptible to Staphylococcus aureus for patients documented as having MSSA colonization. Colonization is not necessarily indicative of a disease process or as the cause of a specific condition the patient may have unless documented as such by the provider. Colonization means that MSSA or MRSA is present in or on the body without causing illness. Example, a nasal swab is positive for MRSA, but the patient has no active infection. The patient is a carrier but not sick. So when you see documentation like MRSA screen positive or MRSA nasal swab positive, that is colonization, not infection. So Z22.322 means carrier or suspected carrier of MRSA. Use this when the provider documents that the patient is colonized with MRSA. Z22.321 carrier or suspected carrier of MSSA. Use this when the provider documents colonization with MSSA. So colonization is not necessarily a disease process. It simply means the bacteria is present. Only assign these codes when clearly documented by the provider. Example, patient has positive MRSA nasal swab, no infection. We have to code Z22.322. Example 2, patient is documented as MSSA carrier only. So we have to code Z22.321. Now the next guideline says about MRSA colonization and infection. If a patient is documented as having both MRSA colonization and infection during a hospital admission, so code Z22.322, carrier or suspected carrier of MRSA and a code for the MRSA infection may both be assigned. If a patient is documented as having both MRSA colonization and MRSA infection during a hospital admission, you must assign two codes. The appropriate code for the MRSA infection, example A41.02 for MRSA sepsis, J15.212 for MRSA pneumonia, or wound infection code plus P95.62 if no combination code exists. So you have to assign that first. After that, you have to assign Z22.322 carrier or suspected carrier of MRSA. Let us see an example. The patient is admitted with MRSA pneumonia and also documented as MRSA carrier. So you have to assign two codes. First one is for pneumonia due to MRSA, that is J15.212 code, and along with that you have to assign MRSA carrier code, that is Z22.322. Let us see another example, that is patient has post-operative MRSA infection and is documented as colonized with MRSA. So here you have to first assign T81.4XXA infection following a procedure code, followed by that MRSA as caused separately B95.62. Along with that, you also have to assign Z22.322 for carrier of MRSA. Now let's move towards the next coding guideline that says about Zika virus infections. Code only confirmed cases. Code only a confirmed diagnosis of Zika virus A92.5 Zika virus disease as documented by the provider. This is an exception to the hospital inpatient guideline section 2H. In this context, confirmation does not require documentation of the type of test performed. The provider's diagnostic statement that the condition is confirmed is sufficient. This code should be assigned regardless of the stated mode of transmission. If the provider documents suspected, possible, probable Zika, do not assign code A92.5. Assign codes explaining the reason for encounter, such as fever, rash, joint pain, or Z20.821 contact with and suspected exposure to Zika virus. So according to the ICD-10-CM guidelines, we only code confirmed cases of Zika virus infection. If the provider documents a confirmed diagnosis, you assign A92.5 Zika virus disease. You don't need to see the type of test in the record. The provider's diagnostic statement is enough to code. This applies regardless of how the infection was transmitted. Now, what if the provider only documents suspected, possible, or probable Zika? Do not assign A92.5. Instead, code symptoms like fever, rash, or joint pain, or use Z20.821 for contact with and suspected exposure to Zika virus. Please like, share, and subscribe to Expert Medical Coding. Thanks for watching.